Okay, good afternoon, everyone. I'm very pleased that we're able to welcome Teck Khong today to talk about the particular issue of excess deaths that we've been seeing in the last few months. And those are excess deaths over and above COVID deaths. And we wanted to go into maybe a bit of nitty-gritty about what the causes of those deaths are, and probably just as importantly, politically, what's the way forward? And the reason I'm so pleased Dr. Teck Khong is here is that his experience is across medical issues, legal issues, and political issues. So he's probably the perfect person to understand not only the medicine, but also politically, how we can move forward, essentially, because there are a lot of questions, a lot of concerns that need to be addressed. So if it's okay, Teck, I'll just introduce your background and you can add in things that I've missed, if that's okay. So your medical training was in Sheffield, where you qualified, and you have also complete legal qualifications from Cardiff University, and have been a police surgeon. Well, the last position you had there was with Northamptonshire. And as well as all of those things, as I understand, while you've been a practicing GP, you've also worked a lot on drug trials throughout that period. So you know exactly all of the protocols and procedures that you need for a sort of safe and effective drug trial, which is also a very big element of the situation we're in today.
Yes.
I think lastly, I'd add on, you've been very, very active politically, and particularly now with the Alliance for Democracy and Freedom.
Yes, indeed. I'm not sure whether many people are aware, the party was actually established back in the latter part of 2019. We had registration from the Electoral Commission then, but because the pandemic interceded in the early part of 2020, we were unable to go out to meet the people. The party is, I believe, quite unique because it's founded by people from all political persuasions. They had family who voted for Labour, the Conservative, the Lib Dems. So from a diverse background, they decided to set up a party that really represented the people, because they found they was getting more and more dissatisfied with the offers from the parties that were supposed to represent either the working classes or the people in business. Essentially, there was very little difference between the two main parties. And we also found that the democracy of this country was becoming more and more distorted and corrupted. And there was, above all, a relentless attrition of freedoms. So the party stands for decency and respect for personal autonomy, which is in this present climate with the mass vaccination program being seriously undermined. We need to look at how we can restore the freedoms, the principles that are time-honored, which founded this country. So we are appealing to the public for support, and we hope this is an opportune time to evince our qualities of democracy at grassroots and respect for personal freedoms.
Yeah, those are values that we're also very, very interested in, and very pleased that we're able to work together on this presentation, which I think is a critical contribution at the moment. So if it's okay with you, what I'll do is I'll dive into some of the numbers that show the causes of excess deaths, and then we can go to your real world knowledge and see how that sort of fits together, basically.
Yes, please.
Okay. Okay, so this is the first chart, and importantly, we've posted together quite a long paper on these numbers, what they mean and where they come from. So we're not going to go through all the detail on this video presentation. We're just going to go through at a high level, and all the detail is in there, and it'll be posted on the websites of the Alliance for Democracy and Freedom and on our website as well. So just briefly, this is the weekly total deaths in England and Wales for this year. And these bars are the total all-cause mortality. And within these bars, you'll see this area at the bottom here. It's quite small. These are the COVID deaths in those weeks. And the one thing I wanted to say here is that the excess deaths above this 5-year average, they are higher than the COVID deaths alone. So what this is telling you is there are excess deaths over summer which are not related to COVID, and that's what we want to get into. What are the causes of those deaths, and what are the scale of those excess deaths in terms of numbers? So going straight in then to a more detailed database, which is available through Public Health England, called the Fingertips database, where you can look in a lot of detail in excess weekly deaths. We've been doing that in the last week or so. We're going to look at two cuts. One cut is by age, and the other one, probably the more interesting one, is the causes of those excess deaths. So this is the view by age. And again, it's a similar picture to the ONS chart, in that you have these excess deaths up here. They've been sort of fairly consistent since July, unfortunately, in the age group of 50 to 64. And the height of these bars is again more than the COVID deaths. So again, that's pointing to excess deaths coming from reasons other than COVID. And that's really what we want to get into on the next slide. So this slide is telling you that there's quite a big concentration in terms of age in this 50 to 64. They actually show up a little bit, but much smaller in the younger age groups. But this is quite a big, you can see this visually on a chart straight away on the 50 to 64 group. So that's, one question for the practical experience, are we seeing this on the ground? Because that's what the data is saying. And then looking at the causes of death, you're able to go through all of these different causes of deaths and look through one by one. This is, in a way, a sample ischemic heart disease, which is, again, showing, we're running here at a couple of hundred deaths a week. And those deaths are not, they're much higher again than the COVID deaths. So this is genuine deaths attributable to ischemic heart disease, and they're not COVID deaths. So, this is a question: why has this turned positive, and where's it heading? It seems to be, unfortunately, quite stable and quite high. And then just lastly on this point, we have been through all of those individual causes of death, and it's too long to go through each of them one by one, but here is a pie chart for the week ending 24th of September, where there were basically 1,000, just under, but nearly 1,000 excess deaths in England, which is, again, more than the COVID deaths for that week. And this pie chart's taken essentially directly from the database, and it shows the distribution. So again, the largest contribution here is from other circulatory diseases. You have ischemic heart disease again, acute respiratory infections in this area, diabetes, and chronic lower respiratory diseases. So again, this has been very quick, but the details will be on the site. But I guess really what we want to hear is from Dr. Khong. Is this consistent with what you're seeing? Have you seen excess deaths over the summer, and does this idea of sort of heart-related conditions and a sort of age profile quite concentrated in that 50 to 64 area, does that Does that ring a bell, and is that what you've seen?
Yes, Alex, thank you very much. I think that's a very good background to some of the things I want to present clinically. First and foremost, ischemic heart disease is the commonest cause of death in the United Kingdom. But we have a difficulty here in terms of interpretation of the results you presented. First and foremost, we need to know what the situation is regarding those people with pre-existing condition and then having the vaccine. Are they compromised in terms of cardiac reserve going forward? Will they be more at risk of developing heart attacks? The other thing is, how many of those people have silent but undetected heart disease and then go on to developing cardiac disease subsequent to the vaccination? These are very important questions. Whether the vaccination has provoked a change and caused a deterioration, or actually precipitated a change that went on to cause cardiac problems. The unfortunate thing is we do not have pre-morbid or pre-presentation angiograms or ECGs in a lot of these people, because we don't test our patient population on everything. So we need to look at the results very carefully and come to a conclusion. And this takes me to the second point. I think the profession needs to be very open-minded and be receptive to all causes. The censorious environment in which we find ourselves is not conducive to the propagation of good science and the practice of good medicine. We should be able to discuss freely without being censored. For example, there are one of my colleagues called Sam White. He has been suspended from practice by the NHS England because of certain things he mentioned in relation to treatment. I think that's entirely prejudicial to the propagation of good medical practice. We also have the problem with open-mindedness and the ability to discuss freely, the ability to understand that these things sometimes take a long time to develop. So if you have a healthy 40-year-old, 50-year-old with no previous heart disease, and you may look back in years to come that the ECG was normal, blood pressure was normal, that it develops problems with the heart. Now, what would you attribute that to? Would that be because of his poor diet, poor lifestyle, or was it because of the vaccine? Well, these are the things which we need to address without prejudice to any party or any medication. And then we also have other problems which are not so easily tested because we have a novel technology and presentations which we haven't studied very carefully. If you remember this group of vaccines, the spike protein based vaccines have been in clinical trials, and with very early efficacy studies, it was released for mass use under the emergency use authorization. I can tell you, having done clinical trials, when we conduct phase 3 clinical trials, we assiduously monitor vital signs and also biochemistry, hematology, and various parameters to make sure that we can detect any change that might lead to serious harm. So we normally stop the trial for those patients where such change is detected. Now, when you offer these vaccines to huge tranches of people in mass vaccination program, there are no such rigors of monitoring. We don't say to people, if you get this, go and see a GP. The GP is not even allowed to talk about it. So I would say the information collated by VAERS in America, and MHRA here, and EMA on the continent, are probably an underrepresentation of the true picture. And the other thing is some conditions have a very long latency period. They don't show up within a week, 2 weeks, 4 weeks, or whatever. it can take years. So an autoimmune condition like thyroid inflammation, thyroiditis, may take years to develop. Do we know what effect it has on potential cancers? We don't. We really need to answer these things before we proceed further. We have even a worse threat as we look at children about to break up for Christmas festive season. How many of them have been vaccinated already? And how many cases have there been of serious complications? We hear of myocarditis. Now, I wrote in the Express newspapers back in February or March, that children have a very low burden of disease. And the mortality from coronavirus, SARS-CoV-2, is in the order of 3 decimal places from 1%. So we're talking about a very infinitesimally small number who might risk. Yet we have reports of children developing myocarditis. One of the things that alarmed me and changed my appreciation of the promise there was with the vaccine came when we had in a practice a lady who previously healthy, young lady of 27 who goes to the gym 4 times a week, turned up the next day after a vaccination with a swollen arm. Most peculiar. So I decided to see if there was actually a clot, because it's most unusual to have that presentation. So the test was taken on a Friday, and the results came back on a Monday. My colleagues saw the results, couldn't understand why the test was ordered, but sent it to the hospital where, again, they couldn't demonstrate any visible sign of thrombosis by ultrasound, but they took serious notice of the D dimer, which was about 5 times above normal, and gave her anticoagulation. The lady's condition settled over the succeeding 2 or 3 days, and she was discharged. Now, I have since looked at patients with swelling of the limbs or various parts of the body, and surprise, surprise, they have actually turned up with raised D dimers. So I would say this: I think before we rush on to continue with the mass vaccination program, and now even offering patients the 3rd booster dose, we should have a moratorium and ask ourselves, the graphs that you presented of excess deaths and the cases that GPs are probably unaware of, to look at any connection between the vaccine and the conditions presented. So I think we have to step back. My party, very early on in the year, asked to have a moratorium and a national debate on the mass vaccination program. I think we owe it to our patients, we owe it to the public, that we approach this now cautiously. And if it's safe, then by all means continue. If not, I think we have to, as alluded earlier, spend more effort in treating the condition as and when it arises. We have a very difficult situation now where children might be persuaded on a Gillick principle or whatever to have the vaccine. I think the use of Gillick principle is contemptible, because this is nothing like contraception. Whereas contraception is very straightforward. If a girl doesn't take the pill, or rather chooses or wishes to take the pill but prevented from doing so, she will discover the fruits of conception without contraception. But this is something which we can't play about. We can't risk young lives when we do not know the risks of cardiovascular complications. One of the things that we need to look at as well is the presentation in partial form. I think there are people with no overt signs of cardiovascular disease, but later on develop full-blown disease. So we have to be very careful.
So in many ways, it sounds like this is a bit of a reversal. When you would normally have any kind of new drug, you would be actively seeking any adverse reactions. Whereas in this situation now, because of the sort of political environment, the encouragement is not to seek those things and actually to sort of not really raise them even as possibilities.
I think it's curiously anomalous. Doctors are supposed to talk amongst themselves and ask questions, and scientists too, and we can ask our more scientific colleagues why we're coming across this sort of problem. But we have a very censorious environment. If we dare talk about it, we are castigated as if we are trying to undermine government policy. But what is the policy founded on? Is it in the best interest of our patients? Is it in the best interest of the public that we give them? Have we forgotten, for example, that immunity exists? I know, for example, there is a latest paper in the Nature magazine journal about a gene called the OAS1 gene. Now, preliminary studies have alluded to the fact that those people with OAS1 gene, when prenulated, offers protection against COVID infections. Should we be determining the presence or absence of this particular protective gene before we give the vaccine? Which patients, which are those patients who are susceptible to getting serious complications from the vaccine? We need to determine those things. I personally think that there is inadequate long-term data. We also therefore do not have enough information to offer to people before they can give informed consent. And talking about informed consent, as I alluded to earlier on, we have children who are unable to decide. Surely Gelling principle can't apply because they don't understand the technology of mRNA vaccines. Neither do they understand the complexities of myocarditis.
Yeah, and rather than, I mean, I think the right way to recognize that would be to go on a soft touch with this because it's new. There are excess deaths. As you said, long-term data is lacking. It would make more sense to sort of go easy with this rather than have one thing I find quite troubling is these quantitative targets and sort of rocket ships of syringes going up with, you know, we've done 6 million, 5 million. Is that really a way to do medicine? As you said, it's the individual's relative risk and benefit has got to be more important than a sort of a quantitative target backed up by coercion and sort of psychological mind games in some of these advertising campaigns.
Indeed. I mean, I have countless requests for exemption. I have nurses up and down the country writing to me via social media. I mean, how can a compassionate government, if you can call it that, think of threatening people's livelihoods based on their acceptance or refusal to have a vaccine that they know, both the patients and the government know, was taken out of phase 3 rigorous monitoring and given now without follow-up facilities? I think it's incredibly bad.
Yeah, and I guess that's what I mean. What your options are to keep raising this issue and focusing in. I think that there is an awareness of the excess deaths, but I think if we keep raising the question, at some point there's a hope that they will sort of pull back a bit. Is that fair?
Yes. Well, I think common sense should tell the government that to coerce people with mandatory requirements or lose their jobs is not the way forward. This country has always prided itself on freedom of choice. That seems to have gone out of the window. We need to demonstrate genuine compassion for our patients. And unfortunately, with the situation the way it is, they have stopped understanding people's concerns. And I think the only recourse is to have a fight back politically. It's a shame, but it's unfortunately unavoidable.
And what would you say to doctors who feel that sort of political pressure, not even to raise the questions that you're talking about, the sort of the D-dimer tests and all of those other things that could actually, as you said, you can't even raise the question, is there any causal link between a patient's problems and recent vaccination? It's a taboo. Is it a taboo subject for many, or?
Always be true to our principles. In order to serve our patients to the best of our ability, we must remain unimpeachable in our standards, and we must take care of our patients with great assiduity. There's no two ways about it. We should talk to each other. We should remain open-minded. We should consider all possibilities, because it is by doing so that we advance our knowledge and prepare ourselves the best ways to treat our patients should they come around. I think, for example, you mentioned about excess cardiac deaths, of which a sizable proportion are ischemic heart disease. But there are other conditions, which I mentioned earlier, with long latency period. So we don't really know how long it will be before a likely complication will show up. It's naive to think that the results would become evident within a matter of days or weeks. But simple logic would tell you, if you think that the vaccine needs to be boosted within a couple of months, surely the side effect can equally take a couple of months to manifest. And the more concerning thing is, if somebody starts to show an adverse event and you give them a second one, do you monitor them? And if they have problems with the second one, do you go on to give a third? And what benefit, what protection would they get from a third? We know, for example, Mr. Sajid Javid, our health secretary, had 2 jabs and got COVID. I mentioned this on a lay interview. I said that the vaccine is based on the original wild strain, but we know the virus has mutated several times, many times, in fact. So if the sequence of protein you took from the original virus that you give to the body to make more copies of and then develop antibodies, when the mutation is of such a degree that this antibody cannot lock on, you have failed in your neutralizing effect. So if the mutated strain comes along and even more mutations come along, why do you continue to give the booster jabs based on the original vaccine? I can't understand. It's absolutely mind-boggling how people would accept that the vaccine would boost resistance or neutralizing qualities when the vaccine has, when the virus has mutated. It just doesn't add up at all.
Yeah. So, I mean, it's the main message that we need less political pressure on a sort of numbers-driven, coerced vaccination, and sort of to step off the accelerator and revert to what we traditionally had. You present the evidence and you let people decide, and you let doctors discuss all eventualities without fear of reprisal for raising questions.
Undoubtedly, Alex. I think the numbers, the statistics released by ONS and PHE, they're hard numbers, but there should be reasons behind these numbers. Let's look at them. Let's look at them and discuss. Let's have a national debate on what the best way forward is going to be. Is it a combination of vaccines with more emphasis on actually treating the cases as and when they arise? Because the mortality rate is actually quite low.
Yeah.
I mean, I remember one evening, my wife said, look, there are so many deaths out of so many positive cases. I said, right, let me take my calculator. So many deaths divided by so many positive cases. I said, that's 0.28%. It's very low.
Yeah.
Do we take the risk? Do we take risks with vaccinating huge populations when the risk is 0.2? And that's only crude figures. They're not, just numbers plucked up from the television. But if the television chooses to use those numbers, I seriously ill patients.
I lost you there a bit from the television. You said if the television chooses to use those numbers, and then it froze.
Yes. Well, what it is if the television chooses to use those numbers, it's very easy for the lay public to pick up those numbers and use a calculator to work out crude figures. The number I had out of the ITV figures a few weeks ago amounted to 0.28%. So you don't even need to dig into ONS figures. Whatever they try to tell you on mainstream media, television, you can actually work out for yourself.
Yeah, good. And maybe just a few words about the party then, because I think the whole medical process has really highlighted, as you said, the whole question of democracy, autonomy, and freedom, basically. This has been an exercise in taking those things away, it feels like. So how will the party politically move forward to try and sort of stop that process and reverse it?
I think the beautiful thing about the party is it is actually very people orientated. They can come in as members and they can tell us what they want. It's their party, they run it. We don't have a whip. We can't believe how somebody in the central office, say at the moment we have an office in Oldham, how that central party can tell people in Hartlepool or Sidcup how to vote. I mean, whatever happens locally, the man there will be able to do best for the people. So we want to emphasize that democracy starts at the grassroots. We also want to emphasize that we want to rebuild the country's fortunes on the individual effort. We're going to encourage personal endeavors. My particular role is to ensure that we have a health policy fit for purpose. Now, back in the 90s, the late 90s, when Labour came to the government, a lot of my patients who are, because I practice in the poor district, one of the 10 poorest districts in the country, they found that the waiting lists became untenable. So what I want to do is to encourage patients to be more in charge of their health. At the moment, we have a tripartite compact that's totally distorted. People pay taxes to the government's supposed to pay the doctors to look after the people. But because money has been used in a way that corrupts professional behavior, I would like to see the thing reconfigured in the manner that patients are actually, the doctors are actually closer to the patient than to the government. The perverse use of financial incentives to reach management targets has been at the heart of the ruination of professional integrity. So that's my eventual role. I would like to help the country regain a cogent health system that really cares with compassion. The party as a whole is going to appeal to people who have been alienated by their previous allegiances. We know that the Labour Party no longer represents the working people, and the Conservative Party are no longer the custodians of conservatism. So we want a party that deals with a whole range of national needs.
Good. I think those are fantastic endeavors, and hopefully we can play a small role in helping where we can, because it's so important now. I think a lot of people have woken up that we're on a trajectory that we've never really seen before, and many of us are worried. We think it's going in the wrong direction, and we need as much political organization as we can get to basically stop this process. And I think many people recognize the alienation from these main parties now, irrespective of red or blue.
I couldn't agree more. I couldn't agree more, Alex. I think we've got to look at politics in the context of people's lives. If we start with the lowest common denominator, we cannot go wrong. You know, when I hear of poor people and veterans without homes, it really breaks my heart. I mean, we're supposed to be a rich nation. We've got to be able to look after our own citizens. And you know, the old age charity starts at home. We've got to look after our people.
Good. What a fantastic, hopeful message to finish with. And I'd like to thank you for your time. And as I said, all the material will be posted, the details of the excess deaths, how those numbers were arrived at. So I think the data seems to corroborate with your experience that this is really a question that needs to be looked at and answered in a sort of free and open way, without coercion and without sort of railroading people through this issue as if it doesn't exist. It needs to be addressed.
Thank you very much, Alex.
Okay, thank you very much. Goodbye.